there was one.
Sorry, go on.
Yeah, no, there was going to be one part where I wanted to show something, but that's not going to be possible. So, but inshallah, we can see how things go. Okay, Bismillah, you guys asked me to talk about female cancers today, so that's what we'll chat about. This topic, unfortunately, is quite dense in terms of facts, but there's a few main points I want everyone to take home with you, inshallah, and we can summarize that at the end. So don't worry too much about the facts and the figures. It's the general gist of it that's important, everyone goes away home with, and the kind of increased awareness of some of these cancers, which unfortunately sometimes are not talked about enough. People can be embarrassed. We're talking about these, there's some stigma around it, and maybe more so in minority ethnic communities and the Muslim community. I want this, again, like last time, to be interactive. So I welcome questions and clarifications as we go along, and we'll stick to time, inshallah, finish for about 1:30. Okay, so let's just start off by looking at the most common cancers in women specifically. So in women specifically, by far the most common is breast cancer. About 31% of all cancers in women are breast cancer. And then the ones after that, specifically in women, so you've got breast cancer, the most common, there's lung cancer, and there's bowel cancer. And together, those three cancers make up 54% of all cancers in women in the UK. So these statistics we're looking at are going to be women in the UK. These are UK specific stats that we're looking at. When we're looking at what are the most common cancers, again, breast, lung, and bowel come top. These are the most common cancers in the UK in women and men. Again, by far, breast has the highest incidence in women. Lung cancer is decreasing in incidence, but unfortunately, bowel cancer is increasing in incidence. And we can talk a little bit about maybe near the end. So remind me maybe to chat a little bit about bowel cancer, because after breast cancer, that's the one that's probably increasing. We're seeing more of in all communities, white, South Asian, Black. There's an increased incidence of bowel cancer. It's a relatively easy one to screen and investigate and pick up for. And the earlier these things are picked up, the better the management and the better the end result and prognosis of these things. So what we're going to cover today, we'll talk a bit about breast cancer, womb cancer, ovarian cancer, and cervical cancer. Those are the main things that we're going to talk about. So I was asked specifically to talk about these sort of female cancers, and by that we usually mean the gynecological cancers, and obviously I've included breast cancer in that. So if there's any questions that come up that if I don't see, if you can just flag them to me or read them out loud, please.
Yeah, sure, will do.
Thank you very much. I think it's important to start off with, well, what is cancer? Because cancer, the word is such a stigma around it. There's so much fear around that word cancer, but there's so many different kinds of cancers. Some are less dangerous than others. And it's important to understand what actually the cancer is. And cancer can happen anywhere in the body, in any tissue, in any organ, because a cancer is the uncontrolled overgrowth of cells. So everything in a body is made up of cells. So you have skin cells and muscle cells and bone cells and liver cells, etc. And a cancer can occur in anywhere where these cells occur. And what happens initially is the cells overgrow, they grow too much. So if you look at this diagram, the first one is of a kind of sectional look at cells, and this is skin in normal healthy skin. If you look at hyperplasia, that means an overgrowth of healthy cells. So you can see the cells are becoming cramped and tight. So this is an overgrowth of normal cells. And then you move on to dysplasia, which is an overgrowth of abnormal cells. So there's something that's happened that's caused the cells to become abnormal, and that can be due to viruses, environmental factors, inflammation, and the old cells are not dying, and they're growing out of control. Okay, hyperplasia and dysplasia are not cancer at this stage. And as you can see, dysplasia looks normal, and hyperplasia and dysplasia may not ever become cancer. But sometimes through certain screening techniques, we can pick things up at this early stage. Now it's only in that last section that you can see this is what cancer looks like. So when these abnormal cells now start invading healthy tissue, that's cancer. So sometimes we talk about cancer in situ. This is what we may call stage 0 cancer. It's not, so the cells have become abnormal, they're overgrowing, but it's not invaded nearby tissue. But cancer in situ is going to become cancer. So we know it will definitely become cancer, it's just a matter of time. So at that point, treatment is always given. But those are the stages that our cells go through before we pick up a tumor or a cancer. It's overgrowth of cells, and cells that have become abnormal, that are not dying when they should, and then start invading normal healthy tissue. Any questions at this stage? Does anyone want to clarify anything, and does that make sense? Okay, all right, let's carry on. Okay, let's talk about breast cancer. It's the most common cancer, like I said, in women by far, and the risk factors are being female, and that's because breast cancer is very strongly linked with the hormone estrogen. Estrogen is the hormone that kind of regulates our period cycles, and it's the female hormone. Age, so increasing age, certain lifestyle factors can increase the risk of breast cancer. In our last talk on menopause, we talked about HRT and the link with breast cancer, and the reason being is when you hit menopause, your estrogen levels decrease drastically. When you give HRT to a woman, you're giving back that estrogen. So a woman on HRT is having estrogen for a longer period of life, but it's all relative. So this risk is relative, which means that we need to take in other considerations. By far, the biggest lifestyle factor and risk factor of breast cancer is obesity, and that again is to do with hormones, because fat cells store estrogen hormone, they hold on to estrogen, and that can increase the risk. Physical activity, breastfeeding are all protective against breast cancer. So in communities where breastfeeding is very common, in communities where women have a lot of babies and breastfeed all their children, you may find that breast cancer incidence is lower. However, those traditional communities and lifestyles are changing in those traditional communities. So we're seeing a huge rise of breast cancer in developing countries as well now. And there is a small increased risk, sort of genetic component of breast cancer. So there's something called the BRCA1 and BRCA2 gene. Usually this is highlighted when women develop breast cancer early, and there'll be a strong family history. So if a woman comes to me and says, I found a breast lump, I'm really concerned because my sister was diagnosed when she was 40 and my mum had breast cancer. So that to me is alarm bells. I would be referring her for genetic testing to see if there's that genetic component in their family history. Okay, so yeah, it's like I say, age is a big factor. Your risk doubles every 10 years after menopause. There are approximately 54,000 new cases and 7,000 new cases of invasive cancer every year. So let me just say that again, 54,000 cases every year. 54,000 women are diagnosed with breast cancer every year. That's a big number. And 7,000 of those will be, there will be early diseases picked up, usually on mammogram. Mammograms pick up lumps that are not even being able to be felt yet. That's why mammograms are important in the screening process, important because they pick up very early lumps, and therefore breast cancer can be picked up very quickly. And remember, we were talking about cancer in situ. Well, that's what a mammogram does. It picks up breast cancer in situ before it's invaded normal healthy cells. It's not just a disease of women. 300 men annually develop breast cancer in the UK. But alhamdulillah, most breast cancers are diagnosed quite early because there's more awareness of examination of your breast and looking at, sort of knowing what's normal for your breast is much more increasing awareness of that. And because of breast screening, we're picking up breast cancers a lot early. And therefore that means that vast majority of breast cancers that are picked up are curable. Okay. 90% of women diagnosed with breast cancer survive their disease for 5 years after their diagnosis. So that's a really good stat. So 90% of women after 5 years will be well and disease free. Unfortunately, it can have a relapse, which is why a lot of women who have breast cancer do get monitored, may get annual mammograms. The treatment is not straightforward and is individualized to the woman. And because there's that link with estrogen, for some women more so than others, it can mean that if a young women that develop breast cancer, they have to give the medication to shut off their hormones, which obviously leads to fertility issues. So it's alhamdulillah, it's a disease that is being picked up early, being managed, is curable, but it can have long-term implications of having children, etc. And also, depending on what stage it's picked up, one of the treatments is surgical. So not, you either get a lumpectomy where just the lump is removed, but then you can also get mastectomies where the whole breast needs to be removed or both breasts are removed. So this is a huge, in terms of the impact of quality of life, it can have quite huge effects, quite detrimental effects on the woman and her family. But like I say, I want to kind of still emphasize the positive in the sense that there's a good treatment and management plan now in place. We're picking up early and it's curable. I think Sister Sarifa has a question. Go on.
Yeah, I just had a question. Well, it's not a question, it's a comment. I've had breast cancer for a whole year before I was diagnosed. I kept going to the doctor because I had other conditions. I'm thinking it was my other condition that was getting worse. Lucky for me, I turned 50 and then I had the 50 NHS screening that we have to do. And that's when my tumor was picked up. But I just think there's a big need of education, and I'm glad that you're doing this work. But it's about people's understanding how much the screening saves lives, because actually it saved my life. I had 2 tumors. One was very aggressive and it was at stage 3. It already spread to my lymph glands. If it had spread anymore, I might not have been here. But the whole year before that, I can't understand why GPs don't ask if anybody else has had cancer in your family, because my auntie had died of it. And the importance of that, because then you get the genetics of having like cancer genes.
Yeah.
So I just think it's really important that our community understand when you are offered NHS screening, that we do take it on board and we do go for that. You can bring chaperones, and that's when I started being an activist around that. That's what I found, is that women were scared and women were not told that they could bring somebody with them. And that helps. So I was just wondering, is there anything that, at local level everywhere that, people are doing to help that kind of awareness? Thank you.
Thank you so much for that, for sharing your experience. It's really brave of you to do that. And I think it doesn't matter what I tell you today, what you've just said is actually just more powerful coming from a personal experience. I'm going to go on to talk about screening and the importance of that. And that's one of my, the take-home messages I want everyone to go home with is take up screening. But yeah, there are issues around it. People don't know what to expect. There's that fear, not understanding what it is that they're being called for. So yeah, no, thank you. Really, I really appreciate your interaction there, and very relevant. Okay, let's talk about, because again, this is exactly what Sister Sarifa is talking about, is that awareness of the, of what is normal for your breast, what's not normal for you, being comfortable talking about issues that may arise with a healthcare professional, breaking those taboos, breaking those stigmas, so we feel more comfortable, we feel more empowered, and then we can go back to our communities, our sisters and our aunts and our friends, and talk about these things. Because once that first conversation is always uncomfortable, but then the second and third will be easier, and we're making it easier for other people out there to come forward. Here's a really good image of some of the symptoms that you should look out for. Okay, now not all of them will be due to breast cancer, and some of them will be what we consider a normal variant. So someone came to me and said, right, I've got a rash on my nipple. It's really itchy, it's crusty, it bleeds sometimes when I scratch. I don't necessarily think, oh, breast cancer is really serious. It's always in the back of my mind, yes. However, common things are common. So the first thing would be, okay, this could be eczema, this could be a dermatitis, this could be an infection, so I will treat as that. If it doesn't go away, I would say to the woman, come back. If it doesn't go away, you need to come back and tell us. And at that point, if the treatment I was giving wasn't helping, then I would be referring this for an ultrasound, the breast ultrasound, and further treatment at the breast clinic. In Scotland, and I'm sure this is probably quite true UK-wide, but in Scotland, the breast clinic is one of the best run referral systems I've seen. When we refer someone with a query, with a breast lump or a breast issue, they're seen usually within 2 weeks, which is amazing. They're seen in 2 weeks at that one-stop clinic. They'll get their ultrasound done. If the ultrasound picks up anything suspicious, they will get that mammogram done the same day. If the mammogram is suspicious, even in the same clinic, they may even get a biopsy, a needle biopsy done at the same clinic. So it's a really great system, and which is why I think breast cancer is getting picked up quicker than it ever was, because it's one of the areas of the NHS referral system that works well. So if you have a red hot lump and you're breastfeeding, probably mastitis, unlikely to be breast cancer, we would treat that. Nipple fluid can be common, especially if it's bilateral from both nipples, and can be other underlying reasons for it. However, again, if you have nipple discharge and you're not breastfeeding, speak to a GP or healthcare professional or nurse about this. The kind of symptoms that concern us most are when someone finds a hard lump in their breast, or there's this sort of sunken nipple. And when I say sunken nipple, it means that you've not had it before and it's developed, so it's a new thing. And there's orange peel skin that you can get around your nipple and breast. So the sunken nipple and the orange peel, that sometimes to do with a lump inside that's pulling the outside skin in. Okay, and often when we examine women, we sometimes feel a lump associated with those symptoms. And then the hard lump is the most common presentation of breast cancer. It's the most common thing that women come to us with when they're with their concern, oh, could this be cancer? And we're always really happy to quickly bring them in and examine them. However, saying that, breast lumps are common. Okay, breast lumps can be common, especially in young women. You can get fluid-filled cysts, which can be a bit softer. You can get things called fibroadenomas, which move about quite a bit, as opposed to a fixed hard lump, which is more concerning. The key is know your breasts. Know what your breasts feel like. Understand what is normal for you. And that requires for you on a regular basis to examine your breasts. Whether that's in the shower, at nighttime in bed, just have a routine. And it doesn't take, and this is what I was hoping to do, just like show you how to quickly examine your breast. The key is just know what's normal for you. Just be comfortable feeling your breast. There's no magic special way of feeling your breast. It's just about knowing what's normal for you. Okay. And that could be after the shower, you put some moisturizer on your cream and you rub your hand over your breast, right into your armpit, sweep your hand under your armpit, and then sweep your hand over to your collarbone and just press with the palm of your hand all over in circular motions. And that gives you a good idea of what your breasts normally feel like. And if there is a change, you can easily feel that. In young women, breasts do change. Over pregnancy, breast changes. When you're breastfeeding, breast change. When you become older, menopause or perimenopause, your breast change. So with age and time, there will be small changes, but what you're looking for is that drastic new change, or that lump that doesn't go away. So maybe at the beginning of your cycle, you feel a lump. After your period, that lump's gone away. Very common, nothing to worry about. But if that lump doesn't go away, it needs to be seen. Sister Sarifa, do you have another comment to make? Your hands up.
To say, for disabled people like me, I didn't have a lump. I just felt pain, and I just felt different in that side of my chest. And I just wanted people to be aware that sometimes you don't feel the lumps. I mean, one of the things that I did as an activist is that I did find some leaflets at the GP about how to examine it, and that saved my sister's life, because she then developed it. But she had lumps and she could feel them, but that's how she recognized them. But just, that some people don't feel lumps. I was big breasted and I didn't feel lumps, but I felt pain and I felt heaviness and I felt breathless and I felt a bit different than my norm. Thank you.
Thanks. Thank you, Sister Sarifa. I think that the take-home message is feel your breasts, know what your breasts feel like, be comfortable doing that. And if you're not, then make an appointment even with your practice nurse to go through that. But now actually there's lots of videos online, just like Sister Sarifa said, there's leaflets and even on YouTube how to examine your breasts, so it's easy enough to find. But like I said, don't worry too much about finding a technique, as long as you're feeling your breasts and you know what's normal for you. That's the key. Right, a mammogram. So we have a screening, breast screening process, NHS breast screening process in the UK, and all women from the age of 50 to 70 will every 3 years be invited to get a mammogram done. A mammogram is a special x-ray of your breast, so it means that you need to undress for this process. It's usually just a kind of radiologist, nurse-led clinic where you pop in, you get the special x-ray done and you go home, and you will get the results in the post, usually in about 2 weeks' time. Like Sister Sarifa said, you can take chaperone along with you, a sister, a friend, whoever you want. The chaperone can go into the room with you, or the chaperone can, if you want just someone to take you to the clinic and be outside, that's also absolutely fine. And like I say, it involves undressing up to the waist. So you need to uncover your top half to get this mammogram done. And that for some people can be quite uncomfortable. But again, stressing the point that this is a medical procedure and it saves lives. So in those sort of situations, it's not only allowed, but encouraged for us to do this. And like I say, it picks up breast cancer before it can even be felt. And as it was in Sister Sarifa's case, like she felt these kind of vague symptoms of being heavy and pain, but there was no breast lump to be felt. But the mammogram can pick up those early kind of changes. However, I saw a campaign recently trying to make mammograms an annual thing for women that are over 50. So remember I said that your risk of developing breast cancer increases after menopause. We are seeing cases in young women as well, but it's more after menopause. That's the most common, which is why the screening is, those that age. There's a campaign to make screening annually for women after 50. There's pros and cons of that. Remember I said this is a special kind of x-ray, which means radiation. Radiation is also a risk factor for certain cancers. So we have to weigh up the risks and benefits of these things. So more is not always necessarily better. Any questions on that? No, okay, let's go on. So like I say, Yeah.
Just about this idea, this point, actually I've gone through menopause quite early, and around 40, not 50. And the second year about around menopause, I got some lumps under the arm, and I've been asked to do mammogram. I've done it, and it was, alhamdulillah, quite okay. But I've been asked that I have to do it like every 6 months or year at least. And actually, I'm not really happy with this, and don't want to go through it, because I know it's kind of risk for getting it if you are not having it actually. So what is your advice?
I think though, if you've been called back early, there will be a good reason for that. And it could be that these lumps need to be monitored. So I think you need to find out more about why you've been called back early.
No, they say just a kind of a prevention, and you have to be sure that nothing happen each year, to do it just for caring, not really there is any other reasons.
So Nabila, in my experience, only in my experience, and I obviously don't know the details of your case, women can be called earlier if they've picked up something that they want to keep a closer eye on. Usually the screening process is every 3 years.
Okay, thank you.
No problem. Right, let's go on to the gynecological cancers. And this is a really important diagram because it's, often women just don't know where those bits are, what bits of the anatomy are we talking about when we're talking about ovarian cancer or root cancer or cervical cancer. What are we talking about? So this is a good little diagram that shows you those anatomical parts of a woman's body, and this resides, so the ovaries, the womb, all reside in the pelvis. So like those bony, so very kind of lower abdomen, where your bladder is, that kind of bony bit where your hip bones are. If you put your thumbs over your hip bones and place your fingers over your tummy, that is your pelvic area. There's a lot going on in that area. There's lots of organs, including your womb and your ovaries. But also, remember, your bladder is sitting just in front. So the bladder is sitting just in front of the womb, but also your bowels. So you've got the large bowel coming down here and then winding around and then out into your rectum. So for women, there's a lot going on in the pelvis. And I'm stressing that point because this is why gynecological cancers can be difficult to pick up, because of the amount of anatomy, like an amount of organs and different things going on. The symptoms for a lot of these gynecological cancers can be vague and difficult to pick up and mixed up with other things going on. Okay. But again, there's some red flags and take-home messages that we will come to. Okay, over 21,000 women are diagnosed every year, which means that 58 women will receive the diagnosis of a gynecological cancer every day. And unfortunately, 21 women die a day of gynecological cancer. This is a huge difference between this and breast cancer. Breast cancer has much higher numbers being diagnosed, but the prognosis is a lot better. Gynecological cancers are more difficult to diagnose, and therefore, because they're being picked up later, can be difficult to manage. Okay, we're going to start off with cervical cancer. 2 seconds. Okay, so going back to this, and wait, so it's pointing to this bit here. This is the cervix, okay, and the opening of the cervix is at the top of your vagina. So just at the neck of the womb. So the cervix connects your vagina to your womb. cervical cancer can affect, cervical cancer usually picked up in women between the ages of 30 and 45, and is very rare below 25. So middle-aged women, okay? In the UK, we've got a really good cervical screening program, and it's estimated that over 4,000 lives are saved each year because of the screening program, because it's picking up really early changes in the cells of the cervix. So remember when we were talking about hyperplasia? And sometimes hyperplasia can go on to cancer, sometimes it doesn't. The cervical screening, the smear test that we get done, picks up hyperplasia, and then you can get localized treatment for that. It also picks up cervical cancer in situ. So hyperplasia at that stage will not be giving you any symptoms, and the smear test is able to pick that up. Okay, I'll come back to that later. It's the 14th most common cancer in the UK in women, but this is shocking. This is something that was new to me. It's the most common cancer in women in Kenya, the second most common cancer in Romania, and the third most common cancer in Pakistan. Why do you think that is? So a question out to you, why do you think it's such a common cancer in these countries? Any thoughts on that? No? Okay. It's because we have a screening program. These countries don't have a screening program. That's it. Bottom line. It's because the cervical changes are being picked up before they become cancer, and they're being treated before they become cancer. So women are being treated for hyperplasia, cancer in situ, and is not diagnosed as cancer at this stage and being treated. So you can imagine the number of, not just lives that are changed, but the number of big operations and impact of quality of life that's being prevented because of smear tests. Unfortunately, cervical cancer is on the increase, and 9 out of 10 of these cases of cervical cancer are caused by a virus called the human papillomavirus. And we may have some questions around this, okay? Because HPV virus is spread by sexual contact. So someone that has never had any sexual contact is unlikely to have the HPV virus. Which then, I think there's a misunderstanding, therefore, in our community of, well, Muslims don't have sex outside marriage, we're not promiscuous. So therefore, the lower rates of HPV virus in our community means that we don't need to have smear tests done because we don't have that much, etc. So that you can see that thought process happening. But you just need to have one sexual contact to pick up HPV virus. And unfortunately, in our community, among Muslims, sex outside marriage, being promiscuous in marriage, outside marriage, is on the rise. So we may know our own history, but we don't know other people's history. You don't know your sexual partner's history. And like I say, one sexual contact can lead to a HPV virus being picked up. The HPV virus in itself doesn't give you any symptoms. It's not a dangerous thing. However, it increases the risk of the changes of cells in your cervix, which can lead to cervical cancer. So a lot of people that you can have, HPV virus in your body and it does nothing, but the cervical cancer that's being analysed, 9 out of 10 of those cases of cervical cancer are positive for HPV virus, which is why, therefore, in the UK, we've developed the HPV vaccine, which means that it reduces the risk of that cells changing into precancers and then cancer later on. And the decrease is by 70%, so it's very effective Okay. I did a bit of research looking at the incidence of HPV virus in the Muslim community in the UK. And the incidence of HPV virus in the Muslim community is 9.6%. So it's still lower than the over general population, but it's not negligible, and it will increase. It will definitely be increasing. And the take home message from this is, please get your smear test done. If you are sexually active, even, like I say, one sexual partner, you should be getting a smear test done. Right, so coming on, I'll speak a little bit about, I'll come back to cervical screening. What are the symptoms of cervical cancer? Number one, most common symptom is nothing. Most people don't have any symptoms. The other thing to look out for is unusual bleeding pattern. The most kind of common one, or the kind of one that would cause red flags, is a bleeding after sex. And that's just, it's a sort of trauma thing. So if you can imagine your cervix protrudes into your vagina, and just the impact of sexual intercourse can lead to a little bit of bleeding. So it's not a huge amount of bleeding. Women will say, yes, I get a bit of spotting after sex, or I have a little bit of spotting, I have a little bit of discharge, stained discharge after sex the next day. That's the kind of symptom that people present with, and that needs diagnosed, that needs investigated. At that point, I will probably do a screen for infection first. Ask them if they've had their smear test done. If they've not, they need to get the smear test done. And then just a vaginal examination, and have a look to see if there's any lumps or lesions seen. Cervical screening, unfortunately, is the uptake in the Muslim women is low. And this is quite a shocker. 28% of the general population of women that are invited for screening don't attend. So that's that's almost a third of women that are invited don't attend. And the uptake in Muslim women is even lower. And of course, there's reasons for that. It's not knowing what's involved. It's the exposure of the aura. It's the kind of inherent idea of modesty that we have. And you go in for this examination, and you have to take your bottom half off. You're exposing yourself. And it can be an uncomfortable procedure. And for some women, if they have any vaginal issues, it can be even worse. So, but I would say, if anyone that has, is sexually active, has been sexually active, needs to get a smear test done. If you're uncomfortable about it, speak to your nurse first. Speak to the nurse to talk through what that procedure involves. It does involve a plastic speculum being put into your vagina to get a swab of your cervix. The whole procedure is over very, very quickly. The nurse normally uses gel to make it easier for the speculum to go into your vagina, just to open up enough just to her to look inside and get a swab of your cervix. Some women get a little bit of spotting afterwards, maybe a little bit of a cramp, but it's over pretty quickly. And the main, I think, issue is that kind of exposure of aura. But again, there's there's a medical reason for it. Vast majority of cases, I've never come across anywhere where the smear test has been done by a man. Our nurses are female, and like I say, I've never come across any male nurse doing smear tests. It's women that are doing it. And if it's not a woman, then ask for a woman. In this sort of case, absolutely it should be a woman doing your test. Any questions on that?
I've just got a question. I think in secondary school, I think they've started giving vaccinations. So do you advise parents to opt in for the vaccination? I think the young boys and the young girls have been offered, especially in secondary school, for the vaccines for this kind of cancers. And I know a lot of Muslim mums, usually the way you said, would think that, our kids won't be sexually active, or it's not something we would need as being Muslims. What do you advise?
I get that. I get that question privately a lot. So every year when the vaccination is rolled out at secondary schools, I'll have some friends or family members text me, and I will always sort of give them the pros and cons. I'm not going to, you know, I don't push people into getting the vaccine. However, I will say that we know that it decreases the risk of a cancer that's extremely difficult to pick up otherwise, and something that's in women that do get cervical cancer, it can be devastating. So if a vaccine is one of those things, is the less people in the community that have HPV, the less people that will get it in the future, even if they're not vaccinated. So it's a community protection. And you know, I've already said, as a Muslim community, yes, we may not be as promiscuous as non-faith groups or other faith groups, but that's changing.
Yeah.
And I think we're losing our, you know, we are not accepting of that fact that our children, our younger generation will experiment and do things that we don't want them to do. And this is something that's protective. Yeah,
community as well, isn't it? Yes.
As a community, yeah, it's very much a community. And on an individual level, your decision may be different, but on a community level, this is a protective thing. This is a benefit, and we can't be naive about these things. Like, I think we are very good at saying, "Oh, not our kids or not our, you know, Muslim youth." Well, actually, no, our Muslim youth, yes, definitely our Muslim youth.
Okay. Thank you.
Okay, womb cancer. Let's talk about womb cancer. Womb cancer is sometimes called uterine cancer or endometrial cancer. Let me just have a look. Hang on. Oh, by the way, if at the end, if you have time, if anyone wants to ask about the treatment for early cervical cancer or the hyperplasia, I can go through that. We can kind of revisit that. Womb cancer. So womb cancer begins usually in the lining of the womb. The lining of the womb is called the endometrium, which is why it's called endometrial cancer sometimes. That's the lining that is shed every month and gives you your bleeding, your period. Okay, so every month the inside lining of your womb is shed and women have a period, which is why that womb cancer is more common in postmenopausal women, because that lining is not being shed. So therefore, there's more chances of those old cells becoming defective and overgrowing out of control. It's the most common gynecological cancer, usually in postmenopausal women, sort of 50 plus. And the sign to look out for is abnormal bleeding. If you have hit the menopause, so the menopause is the day it's been 1 year since your last period. That's menopause. So if you're post that period, that time, and you develop any vaginal bleeding, you need to speak to your GP. Okay, 90% of endometrial cancers are diagnosed because it's been reported as postmenopausal bleeding or some irregular vaginal bleeding. So what does irregular vaginal bleeding mean? It means any bleeding after the menopause. It means bleeding in between your periods. It means bleeding after sex, and it means bleeding that's unusually heavy for you. So there's some women that always have heavy periods and that's normal for them. But there'll be some women that, you know, they'll know this, that's different for them, it's a change. And again, on that note, and I think we spoke about it in the menopause talk, was as you're becoming perimenopausal and you're becoming closer to that age of hitting menopause, your periods change. For some women, unfortunately, it means periods become irregular, periods can become really heavy. So this is where I'm talking about, there can be this kind of overlap of what's normal and what's not normal. And if if there's any unusual activity, any abnormal change of your bleeding, speak to your GP or your healthcare professional or your nurse to discuss that. The number one risk factor for womb cancer is estrogen, excess estrogen, which is why when we give HRT to postmenopausal women or menopausal women, we don't just give estrogen, we give the other hormone, progesterone, which protects against womb cancer, which is why HRT does not increase the risk of womb cancer when done properly. Okay, I've talked about risk factors. Oh yeah, the other risk factor for womb cancer is obesity. Again, that's linked to the estrogen being stored in fat cells, and obesity can increase the risk of womb cancer by 10 times the normal. Management depends on when it's picked up. If you have any of this or abnormal bleeding pattern that we've discussed, speak to the GP or your nurse. They'll do a physical examination of your pelvis. They may want to examine inside your vagina and have a feel of the lower abdomen. They want to rule out infection. They want to make sure that you've had your smears up to date, which is really important. And they may then send you off for a vaginal ultrasound or a normal ultrasound. Ultrasound is basically that scan you get when you're pregnant. A transvaginal ultrasound is the same kind of thing, but they put a probe in your vagina because it gives a much better picture of what's going on in your womb. Obviously, if people feel uncomfortable about that, they should speak to their GP before being referred, or when when they're getting that scan done, speak to the radiologist. And again, if it's a male radiologist, ask for a female. You're within your rights to ask for a female radiologist to do that investigation. Okay, ovarian cancer, not as common as womb cancer. It happens again postmenopausally, so age is relevant. And unfortunately, this one is often diagnosed late. And the reason being is the symptoms can be very vague. Symptoms include lower abdominal pain, swelling, constipation, pain during sex, just like a full feeling, urinary problems. So remember I said to you that in the pelvis there's so much anatomy, so many organs going on, and this is one of the reasons that ovarian cancer unfortunately is picked up late, because often it's asymptomatic, like there's no symptoms, or the symptoms can be quite vague. Yeah, so when it's diagnosed early, the outcome can be very optimistic. However, symptoms are vague and they can mimic things like irritable bowel. They can mimic like premenstrual syndrome. So it can be difficult to recognize in the early stages. And most women, unfortunately, when it comes to ovarian cancer, are not diagnosed until the disease has spread. So if a woman comes to me with, say, fullness in her lower pelvis, odd symptoms, kind of pelvic symptoms, and I've ruled out any bowel problems and I've ruled out any bladder problems, I would probably refer her for an ultrasound. And I might even do a special blood test. And the blood test is called CA125. But the unfortunate thing is, this is not specific for ovarian cancer, because if you have any period problems, it will be high. If you have certain bowel problems, it can be high. So it's a really odd blood test. But the ultrasound is a good kind of investigation to send women for, get ultrasound done, and it picks up any masses in the pelvis. Any questions on that? Remember I said about the family history of breast cancer being relevant? Family history is really important here as well. Ovarian cancer is linked with breast cancer in certain in families to do with that BRCA gene. And in some families you may have, say my sister had breast cancer, my mum had ovarian cancer. That's enough for there to be red flags. That's enough for that family to be sent for genetic testing to see if they've got either BRCA1 or BRCA2 gene alteration. Because if they do, if that's picked up, and if there's a strong family history, some women are actually advised to have their ovaries removed because the chances of them developing ovarian cancer can be high. And I know of cases where women have been advised to have their breasts removed as well if they have that gene in the family. Fortunately, it's rare. It's quite rare. So far, I've not seen it in the South Asian Black community very much. It's more in the white community. That not that it doesn't exist, but I've only ever seen it in white population. Quick mention of the vulval and vaginal cancers. Rare, okay, very rare. Usually there's a lesion to be seen or felt. And it's a lesion like a mass or a spot, or your skin changes around there and it's not going away or it's not getting better. Maybe it's a lump, maybe it's a swelling. So again, if you're not sure, speak to a GP or a healthcare professional. If it doesn't doesn't go away, it would need examined. Again, there's issues around exposure of your aura to get examined. At your GP surgery, ask for a female GP. If there's no female GP available, maybe ask if there's a female nurse. If there's no female nurse, remember you can always take your own chaperone with you, or someone from the surgery can be a chaperone while you're being examined. And again, in medical cases where there's a need and it's to do with your health, this is absolutely allowed. Key take-home messages: please go for your smear test when you're invited. If you're sexually active, get your smear test done. And if you're 50 and over, go for your breast cancer screening. It'll take a few hours out of your day. It's not painful, and it's picking up early cancers, which means that if it's picked up, your prognosis, the end result, is very good at that stage. Know what your breasts feel like, be comfortable feeling your breasts, and know what your breasts are like so you can pick up changes. Remember the gynecological cancers we've talked about, the symptoms can be vague, non-specific because by other things. If you're not sure, speak to a healthcare professional about it. Unusual bleeding is a red flag. If there's bleeding in between your period, if there's bleeding after sex, and if there's bleeding after menopause, those three unusual bleeding patterns do need investigated, okay? And what are your risk factors that you can control? Because in some cases, you can't prevent the cancer, but in other cases, there are certain risk factors that make it more riskier, more likely that you may develop a cancer. Diet. Well, remember I said to you about bowel cancer on the rise, and we're seeing it in younger and younger people. It's linked with diet. A diet of processed food, a diet of rich in meat, a diet that causes people to be more constipated, not emptying their bowels properly, causes inflammation in their gut, a diet that means that they've got poor gut bacteria, is all increasing the risk of bowel cancer. So yeah, the factors that you can control are your diet, your weight, and smoking. Those are the three lifestyle factors that are very closely linked with a lot of cancers generally, and some of the ones that we've talked about today. That's me. Do we have time for questions?
Yeah, thank you so much. That was really interesting. You covered quite a lot, so thank you so much. I think we do normally struggle to get all these women-related topics under one, so you've summarized it really well. So thank you so much. Hopefully, the awareness will help as well. It's never too late to be safe and to get investigated, just for that peace of mind as well. So thank you. We will open up to questions. You can unmute yourself, or you can write in the chat as well if you have any questions. So it's just for the audiences as well. If anyone has any questions.
Yes, please.
Yeah, sure.
Yeah, can you please give us a quick information about hormonal therapy, and how it's really not giving a chance for getting cancer in other way, and it's helping in not getting cancer in another way. It's quite confusing because it's a hormonal. So
we spoke more about this in our last talk on menopause, and I kind of talked about HRT because there's lots of misconceptions about HRT, and it's not just in regards to cancer, HRT can be protective against cardiac disease, heart disease, and vascular problems as well. It can also be, it also protects your bones from thinning. The number one cause of death in men and women as they get older is heart disease. So it's not even cancer, it's heart disease. And HRT, when given correctly, can be protective against those things. And like you say, it's protective against some cancers, like ovarian cancer, but it can increase the risk of other cancers like breast cancer. So we have to individualize it to that patient and be, we need to know the patient's history. But in majority of women that I speak to, the benefits do outweigh the risks. So for generally a well, healthy woman that wants to think about HRT, chances are that it's probably going to be good for her for a few years. It's only after 5 years that we will start discussing, okay, breast cancer risk, etc. But for the first few years, HRT is more of benefit than, the benefits outweigh the risks. But also in that talk, I hope I did kind of drove home the message that your perimenopausal and menopausal symptoms can be improved through lifestyle. Number one, through lifestyle, by eating better, by getting exercise and movement, by looking after your emotional health. These things can have a huge impact, but those are the things that we should develop the habits of earlier. So women that come into the perimenopausal time, if they are generally of better health, they will have less menopausal symptoms.
Yeah, we will. I think I've shared in the ICRA Library WhatsApp the PowerPoint as well. So if anybody does want it again, just message me and I'll send the PowerPoint as well about menopause. It was a really interesting one. I think we didn't record it, but we had the PowerPoint as well, and Sister Sahira went into detail with that. So thank you so much. Just a question that someone's asked: if they're under 50, they've not received a letter for a mammogram. So for them, do they just is it just checking on themselves whether they've got any lumps? Is that what you advise?
Yeah, absolutely. Yeah. So again, I would say just be in a habit of every week examining your breasts. It should be just in the shower, something you do. Sweep your hands over your breast, one side and under your arm, into your armpit, feeling for lumps, and up to your collarbone, feeling for lumps, and do that on both sides. And sometimes remember, because it's every 3 years, you may not get a letter when you're 50, you may get that invite when you're 52 because of that cycle every 3 years. So it can be anytime between 50 up to 53 when you receive that first letter.
Okay, excellent, thank you. If anyone has any questions? I think, Dr. Sahira, you haven't mentioned about the treatments of these cancers, but I suppose that would be individualized, isn't it, by the consultants, right?
Yeah, very much. I mean, like say breast cancer can, it's from surgical procedures to chemotherapy to radiotherapy to hormone therapy. Cervical cancer, like I say, a vast majority of them picked up really, really early. So they get sometimes those cells are just frozen locally under local anesthetic, and those are day cases. So it really depends on where the cancer is and what stage the cancer is at. Is it still localized or has it spread? And management really differs hugely depending on that.
Okay, thank you so much. If anybody has any questions before we end, Dr. Sahira has covered the topic really well, and alhamdulillah, as we say, that we're really lucky that we've got this kind of sessions to create this awareness as well. So we will share the recording in the ICRA Library WhatsApp group as well. So anybody that's missed the session or anybody that would like to rehear the session, you can do that as well. So once again, has anybody got any questions before we end?
No question, but just a comment.
Yeah, sure.
I was very apprehensive to go for the mammogram. And usually I avoid hospitals, and for this I was quite apprehensive. But I did go, and believe me, it was worth it, and there was nothing invasive. I mean, I had to undress up to my waist, but it was brilliant. There was nothing wrong, and there was no pain, and it was done very well, and the results were alhamdulillah good.
And Sister Mamuna, thank you for sharing. You know, again, what's more powerful than me telling you facts and figures and telling you to go for mammograms is you talking to your friends and families and nieces and about your experience, because that without doubt will empower them, knowing that you've been through it and you said, yeah, it's absolutely fine. That's what's going to encourage people the most, is these experiences.
So,
Yeah.
Thank you
Thank
so
you.
much for
Thank you,
sharing
thank
that.
you.
Thank you. Thank you
Thanks.
so much for sharing that. As I said, it is, you know, when somebody's gone through that and they appreciate, and we're lucky, alhamdulillah, in UK that we do have this, you know, screening processes around as well. So let's make the most of it. And inshallah, you know, the rest is in Allah's hands. We try our best from our side in terms of the risk factors, what we can control. The rest is all in Allah's hands. But let's, as Sister Dr. Sahira mentioned, it is important that it's picked up early, because obviously the prognosis, it helps with the prognosis as well. So let's pray for everyone, inshallah, all those who are suffering, all those who are ill around the world. Let's pray for them. Let's pray that, you know, we're looking after our health, more proactive with our health as well, and carry on with that. So thank you so much to Dr. Sahira for today's session. Thank you to all of you for taking that time out. And inshallah, we'll see you next time. Enjoy your Friday. Keep us in your du'as. Khuda Hafiz.
Assalamu alaikum.